Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. My email is sreeklpm@gmail.com. Today we are going to talk about a very interesting topic, spinal cord disorders and paraplegia part 3, the best clinical approach. Spinal cord disorders and paraplegia part 3, the best clinical approach. This is perhaps the best clinical approach to a person suffering from paraplegia. The clinical approach. A careful history and physical exam can help identify a myelopathic syndrome with various patterns of spinal cord involvement that may narrow the differential diagnosis. History and examination are very important to arrive at a diagnosis. History. Bilateral symptoms such as numbness or weakness in both legs or arms suggest a spinal cord localization. Crossed symptoms with weakness in one leg and a loss of sensation, that is a spinothalamic tract involvement in the other, are indicative of a hemichord syndrome, that is the Brown-Sequard syndrome. In Brown-Sequard syndrome, the pyramidal tract and posterior column manifestations are on the same side, but the manifestation of spinothalamic tract lesion is on the opposite side. So which suggests a Brown-Sequard syndrome. History of spasms and stiffness in the extremities with a band-like tightness in the trunk again is consistent with a spinal cord lesion. Gait disorder in which there is a primary sense of instability that is disproportionate to the degree of weakness or numbness again is suggestive of a spinal cord lesion. A sensory level is common in spinal cord disorders and is often described as the zone in the trunk beneath which the sensation is diminished. Example, numbness below the umbilical line is with a T10 sensory level. Although urinary urgency, hesitancy and anal sphincter dysfunction are commonly associated with myelopathy, they can sometimes be absent until late in the disease, most prominently in compressive disorders of the spinal cord such as Spondylotic myelopathy. Lehmert's sign. An electric shock-like sensation through the back elicited with the neck flexion can be present in lesions affecting the posterior columns of the cervical spinal cord. If this Lehmert's sign is seen in elderly, we should always suspect cervical spondylosis and in young multiple sclerosis. So Lehmert's sign is because of the posterior column involvement in the cervical cord. Intramedullary lesions are less likely to cause pain and more likely to cause symptoms related to the disrupted tracts such as bowel or bladder dysfunction from involvement of the autonomic fibers. Anterior horn cell involvement may cause fasciculations with muscle loss in the affected myotomes. This is the diagram on the cross section of the spinal cord. Examination. Given the dense packing of the gray and white matter in the spinal cord, even small lesions can present with large deficits. To understand the various syndromes and the clinical manifestations, we need to understand the tracts, the descending motor tracts and the ascending sensory tracts in the cross section of the spinal cord. First, let's talk about the ascending sensory tracts. The two important tracts are the spinothalamic tract and the posterior column. The posterior column carries touch, position joint and vibration sense. They are placed posteriorly in the spinal cord and they are supplied by the posterior spinal arteries. The other tract is the spinothalamic tract, which carries pain, temperature, sensations, and this tract, as it ascends, it immediately crosses over to the opposite side and then ascends. A very important point. Because it crosses immediately, the sacral fibers become the peripheral most, then the trunk fibers, then the upper limb fibers. So sacral fibers become the peripheral most, as you can see in the diagram. So if there's an extramedullary lesion, the sacral fibers are the first to get compressed and therefore the sacral sensory loss is there. Whereas if it's an intramedullary lesion coming from within the cord and going outwards, The sacral fibers are the last to get affected or may not get affected because they are placed peripherally. So this is known as sacral sparing. So sacral sensory loss is seen in the extramedullary lesion. Sacral sparing is seen in the intramedullary lesion. Second important point with the spinothalamic tract is that it ascends and crosses immediately, traverses and goes to the opposite side, and therefore any lesion arising within the center of the spinal cord will affect the crossing or traversing spinothalamic tract, but spares the posterior column, which does not cross in the spinal cord but crosses at the level of the medulla oblongata. So any lesion which arises in the center of the spinal cord, central cord syndrome, like syringomyelia, will affect the crossing spinothalamic tract but not posterior column, which does not cross, and therefore the sensations carried by the spinothalamic tract, namely pain and temperature, are lost, but the sensations carried by posterior column, that is touch, position, joint, vibration sense, is spared. This is known as dissociated sensory loss. Dissociated means going away, association means coming together. So in central cord syndrome like syringomyelia, the sensations carried by the spinothalamic tract, namely pain, is affected, whereas sensations carried by posterior column, touch, is spared. Very interesting phenomenon. A person, when someone touches them, they are able to appreciate, but a person with syringomyelia, when he keeps the hand in the fire, they are not even able to appreciate the heat of the fire. The pain is lost. The pain and temperature are lost. So very interesting. If such is the history forthcoming, then the diagnosis is dissociated sensory loss, and the lesion is the pathogenic mechanism, and the disease causing this is syringomyelia. Right. And then the posterior column is placed posteriorly, which is supplied by the posterior spinal cord, posterior spinal artery. The spinothalamic tract is supplied by the anterior spinal artery. And then we have the other, perhaps less important tract as compared to the spinothalamic and posterior column, that is the spinocerebellar tracts. They carry the proprioceptive information at a subconscious level. So even at a subconscious level, we know where our body parts are. Another important point is that the posterior column and pyramidal tract are well myelinated tracts, and spinothalamic tract is the least myelinated tract. So if any lesion which affects the myelin sheath, like an autoimmune disorder like multiple sclerosis, which affects the central nervous system, or Guillain-Barré syndrome, which affects the peripheral nervous system, or deficiency of which will affect the myelin formation, like vitamin B12 deficiency, subacute combined degeneration of the cord, these diseases which predominantly affect myelin sheath definitely will produce symptoms wherein the myelinated tracts are involved, namely the posterior column, pyramidal tract, optic nerves, and cerebellum. The spinothalamic tract are not involved in demyelinative or dysmyelinative lesions or deficiency because of vitamin B12. It is because they are least myelinated tracts. So posterior column and pyramidal tract are well myelinated tracts, and spinothalamic tract is the least myelinated tract. These are the important concepts of the sensory system. When we come to the motor system, the important tracts are the corticospinal tracts. The corticospinal tract, to begin with, the upper limb fibers are laterally placed and the lower limb fibers are medially placed. So when there is an extraneous lesion coming and compressing the spinal cord at the level of the medulla oblongata before they have crossed, it affects the upper limb fibers first, then the lower limb fibers on the same side, then the lower limb fibers on the opposite side, then the upper limb fibers on the opposite side. So a U-shaped or around the clock type of weakness is seen in a lesion at the level of the medulla oblongata, which is known as Ellsberg's phenomena. So upper limb fibers are laterally placed and the lower limb fibers are medially placed, but as they cross over, the lower limb fibers become lateral most and the upper limb fibers become medial most, as you can see in the diagram, lateral corticospinal tract. So this is after crossing. Corticospinal tract has got a predilection for distal limb muscles and specifically some muscle groups in the upper limbs and the lower limbs. For example, corticospinal tract innervated muscles are deltoid and external rotator of the shoulder, triceps, extensors of the wrist, extensors of the fingers, and supinator. Since the supinator is affected when they are asked to extend the hand, since the supination is weak, the pronator will take over. This is known as pronator drift. So a person has got pronator drift, it indirectly implies that the supinator is affected, a corticospinal tract involvement, and therefore it is a subtle sign of hemiparesis or corticospinal tract involvement, called pronator drift. Very, very important. Likewise, in the lower limb, it affects the hamstring group of muscles and the dorsiflexors of the foot and the dorsiflexors of the fingers. So it affects the hamstrings group of muscles in the lower limb. This is about the corticospinal tract. The vestibulospinal tract is concerned with the extension posture. You can see in the diagram, vestibulospinal tract is slightly medially placed. So when there is a lesion, an incomplete lesion, the vestibulospinal tract is spared, and therefore it results in extension posture, which is known as paraplegia in extension. But if the lesion becomes more complete, even the vestibulospinal tract is also affected. The extension is completely affected, which is subsided by the vestibulospinal tract, and therefore person goes in a state of flexion, which is known as paraplegia in flexion. So these are all the important concepts of spinal cord disorder. So unless we know these important concepts, we cannot proceed further. Depending on which tracts are affected, symptoms can include limb weakness, muscle stiffness or cramping, sensory changes or autonomic dysfunction manifesting as bowel, bladder or sexual impairment. Determine the dermatobal level at which the deficit occurs aids in localizing the lesion and is the hallmark of the spinal cord dysfunction. Corticospinal tract injury acutely causes flaccid paralysis, often referred to as spinal shock. During this acute period, reflexes and autonomic function may be depressed, but after days to weeks from the insult, weakness to the hypertonia and brisk reflexes dominate the picture, usually with extensor plantar response known as Babinski's sign. A lesion to the sensory tracts produces a sensory level pinprick testing, which marks the most caudal transition between the normal and abnormal sensations. An autonomic level can be obtained by scratching the skin along the spine for a wheal and flare response. The lack of flare indicates a disruption of autonomic fibers. The dorsal columns are the large sensory fibers that carry pressure, vibration, proprioception and localized touch sensation. A lesion in these fibers leads to diminished vibratory sense and produces gross defects of imbalance and gait dysfunction. So gait dysfunction in a spinal cord lesion is predominantly because of the diminished vibratory sense. The identification of tracts involvement helps to identify syndromes of spinal cord involvement, which leads to a targeted differential diagnosis. So what are the spinal cord syndromes? Complete cord lesion, clinical syndrome, tracts involved localization, common differential diagnosis. Complete cord lesion. So what are the tracts involved? Bilateral spinothalamic tract, dorsal column and corticospinal tract. The common differential diagnosis for a complete cord lesion are non-specific, any major trauma, hemorrhage or inflammation. Second category is the Brown-Sequard or hemicord syndrome. There is ipsilateral dorsal column and corticospinal tract involvement, and the manifestations of the spinothalamic tract will be on the opposite side, contralateral side, because the spinothalamic tract crosses over and then ascends. The common differential diagnosis for a Brown-Sequard syndrome are non-specific one: trauma, compression, inflammation and vascular lesion. The dorsal column, the syndromes, only the dorsal column tracts are involved. So the common differential diagnosis is syphilis, tabes dorsalis usually affects the posterior column. Multiple sclerosis, as I said, multiple sclerosis is a demyelinating disease. So the large myelinated tracts like posterior column gets affected. Posterior spinal artery selectively supplies the posterior column. So posterior spinal artery involvement causes only dorsal column involvement, and copper deficiency. The next category is the subacute combined degeneration, otherwise known as posterior lateral syndrome. The tracts involved in the localization are bilateral dorsal column and the corticospinal tract. Vitamin B12 is essential for myelination, and therefore the tracts which are well myelinated like corticospinal tract and the posterior column gets affected. So vitamin B12 deficiency predominantly causes this subacute combined degeneration. The other causes being vitamin E, copper deficiency, zinc toxicity, HIV associated vacuolar myelopathy. Anterior cord syndrome. The tracts involved are the spinothalamic tract and the corticospinal tract. The common differential diagnoses are anterior spinal artery occlusion, inflammation, spinal artery infarction. The central cord, where the central part of the spinal cord gets affected. So the tracts involved localization are the bilateral spinothalamic tract, plus or minus autonomic fibers and corticospinal fibers. The classic diagnosis is syringomyelia. It could be because of trauma. It characteristically produces dissociated sensory loss. Anterior horn category, that is poliomyelitis. The tracts involved localization are motor neuron, anterior horn. The common differential diagnosis are arboviruses, West Nile virus, which has got a proclivity for the anterior horn cells. Enterovirus like polio has got a proclivity for the anterior horn cells. Then motor neuron disease, we have a type affecting only the anterior horn cells known as progressive muscular atrophy. Anterior horn cells plus upper motor neurons, and both upper motor neuron and lower motor neuron are involved. So what are the tracts involved? Motor neuron, anterior horn and the cortex. And the common differential diagnosis amyotrophic lateral sclerosis, where the anterior horns are involved, known as progressive muscular atrophy, or corticospinal tract supplying the spinal cord, which is known as primary lateral sclerosis. When both are affected, upper motor neuron and lower motor neuron, we call that as amyotrophic lateral sclerosis. Sometimes compressive radiculomyelopathy also can affect the lower motor neuron and upper motor neuron. Conus medullary, where the tip of the spinal cord gets affected, we have variable tracts involved. It could be corticospinal tract, spinal thalamic tract, dorsal column or autonomic fibers are variably involved. The differential diagnosis: compressive, inflammation and spinal cord infarction. Yeah, having known all these differential diagnoses, how do we approach? There are so many causes. How to remember? It is easy to remember with the mnemonic. So the differential diagnosis by mechanism, very easy to remember all the diseases affecting the spinal cord by mechanism by a mnemonic known as Vindicate. VINDICATE, Vindicate. So what do these first letters stand for? V is for vascular, I is for infection or inflammation, N is for neoplasm, D is for drugs, toxic or degenerative, I is for iatrogenic or idiopathic, C is for congenital, A is for autoimmune, T is for trauma, E is for endocrine or metabolic. So the mechanism, the differential diagnosis of spinal cord disorders by mechanism is by remembering the mnemonic Vindicate, VINDICATE. The differential diagnosis by time course. So what are the differential diagnoses? Hyperacute, very sudden in onset, we have to think of compression or vascular. Acute to subacute, slightly, it presents suddenly but not very sudden in onset. Then we think of infection, inflammation, compression, vascular, neoplasm. Chronic, going on for some time. It could be infection, toxic, metabolic, degenerative, compression, vascular. Acute, presents acutely, then it plateaus off. Acute presentation with plateau, we think of vascular. Less commonly infection and inflammation. Acute presentation with progression, compression, infection and inflammation. If there are intermittent flares, we have to think of inflammation or dural arteriovenous fistula. If it is progressing very slowly, insidious, we have to think of chronic myelopathies. So differential diagnosis by pattern of progression. Acute deterioration with plateauing, it is vascular. Progression, it could be structural abnormality, infections, inflammation, inflammatory etiology. Progression with intermittent flaring processes, we think of dural arteriovenous fistula or multiple sclerosis. Slow and steady progression over years, we have to think of chronic myelopathies. Yeah, then we go for imaging, investigations. After history and examination, we go for investigations, imaging. Abnormal cord signal on MRI is usually not specific for a single disease, but individual pattern of abnormalities circumscribe the list of possibilities. So MRI features and the differential diagnosis. MRI features may be longitudinally extensive, short segment or central lesions. Longitudinally, if the MRI shows a longitudinal extensive lesions, there are so many causes as given the differential diagnosis, but one disease we should always think of is neuromyelitis optica. Likewise, when we take MRI, when the short segment is involved, again there are so many causes, but we should always consider multiple sclerosis. Central lesions, if the central part of the spinal cord is involved, there are so many causes, but we should always consider syringomyelia. So longitudinal extensive, neuromyelitis optica, short segment, multiple sclerosis, central lesions, syringomyelia. Then we go for CSF studies. We look for cell count, protein and glucose. Oligoclonal bands and immunoglobulin index suggest demyelination. Autoantibodies suggest demyelination and inflammation. Specific viral or bacterial antibodies and PCR suggest infection. Flow cytometry or cytology is used for malignancies. Yeah, so this is the best way to approach a person suffering from paraplegia. I feel this is the best clinical approach. Most of the neurology concepts I have put in a question answer format in a book written by me, Focused Neurology, and the author Dr. Sreenivas. It is available online from all leading book sellers, particularly Amazon. So this book is available on online Amazon. These are the important concepts of spinal cord disorders and paraplegia: the localization, the differential diagnosis, and the best clinical approach. So I hope you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly get back to me through my YouTube channel, Dr.Sreenivas Medical Concepts, or by my email, sreeklpm@gmail.com. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my web page, Dr. Sreenivas Concepts. Thank you. Bye.